Phyllis Butos come in to talk to me about the importance of psychosocial care in general. It's an area I know you've been involved with for quite a long time, and you've done a tremendous amount of research. My first question for you is, how do we translate what you find in the research setting into the clinical domain, which eventually hopefully filters into patient care?
Yeah. Well, I mean, I think that's absolutely essential for all research in the planning of the research phase, even before you actually do the research, to make sure that what you are studying is important to patients and clinicians, acceptable to patients and clinicians, and will actually result in better outcomes. So I think when we're designing research, we have to have those in mind. In terms of how do we do it afterwards, most of the research that we do, that I've been involved in, has been around communication and support of patients. We translate what we find about where there are gaps in communication into resources for patients and clinicians, whether it be training packages for clinicians in how to communicate more effectively, or resources for patients, such as lists of questions that they might like to ask. By creating really practical things like that, we make sure that it gets translated into practice.
Do you think it's important that everything in clinical practice is evidence-based? Should we test almost everything we do, even if it's things that we have certain assumptions they definitely work? Or do you think certain things can be given a pass? In other words, they've been there so long, we don't really need to test everything?
I mean, I think that because there is a cost to everything that we provide in healthcare, and because of the increasing attention to cost, we really owe it to the funders and the government and to patients to make sure that what we provide is evidence-based. And there are some great examples of things that have been used for many, many years that, when actually evaluated, were totally ineffective, both in medicine and in psychology.
Yes.
So I do think that it is really important that we do evaluate what we do, and evaluate it not only in perfect settings, but in usual care.
Is your experience that when studies are recruiting to research, when clinicians are asking patients, will you come on board, or researchers are asking patients, is your experience that the research is fully and logically explained? Do patients always know what they're getting into? Because sometimes in my experience, for example in drug trials, patients actually have a very woolly understanding of what the arms are or what randomization means.
Yes.
Can we do a better job there, do you think?
I certainly think we can do a better job, and we've done research on how to get informed consent, and I think some of the communication strategies that are important for general patient care are also important for research and how we conduct research. So there's always a problem with too small recruitment to trials, which slows them down and makes it difficult to know whether they really truly represent what patients feel, because if large groups are not participating in research, we can't really know that the findings are relevant to them. So it's really important that we do explain things better to patients, and that we really engage with them in doing this research, and they can see the benefits of participating in research, if not to them, then to their children and future generations.
Does that also mean we should do a better job about feeding back the results of research that people have participated in? Because I've seen regularly where patients have signed up to something, but really they don't know whether it's concluded or come out, or...
Yes, I mean, I think there's an ethical obligation to people who participate in research, but also one of the things that we teach clinicians to do when we're training them in getting informed consent is to explain to patients where standard care that they've probably experienced has been based on earlier research findings, and when they can see that connection, that the care that they've got has been because people in the past have participated in research, they're usually much happier to participate in that research and understand the whole cycle of research into clinical practice better.
I want to come on now to the area of communication skills, because if ever there was an area where the research should be translated into the clinical domain. It's on communication skills.
Yes.
You've done a lot of work there, tremendous work on the strategies to improve communication, education behind the scenes. A very basic question for you though. Why do you think our colleagues in oncology and hematology struggle so much at baseline with communication over bad news, details of progressive disease, not just the diagnosis but also prognosis? What's your feeling on why it's such a difficult area fundamentally to solve in a way?
I think for both health professionals and patients, discussing difficult topics like prognosis, particularly a poor prognosis, is humanly challenging. Doctors are trained and go into the profession to be able to solve problems and help people and cure people. And it's almost an admission of failure to them to have to tell a patient that they're not going to do well. And for patients, of course, they're confronted with the existential crisis of this could actually threaten my life. So they're not easy topics. They wouldn't be easy for anyone. And our health professionals often lack training in these areas, and they're not well supported in managing both their own emotions and the emotions of the patient when they're talking about these topics. So there's a real need for system endorsement of the importance of training in these areas, because it has an enormous impact on patients in the long run if health professionals are not supported and trained to have these conversations effectively.
One thing I've noticed in the literature is what I would term an extinction effect, where clinicians are trained, but after the training's finished, the difference tends to diminish. The positive effects of the training gradually wear off. I mean, I'm just wondering, what is the possible answer to that? Does it prove that the training was effective because it was definitely there initially, or does it prove that it wasn't really worthwhile because it wore out over time?
I think that in part reflects the importance of the system approach, because individual clinicians may become inspired at a communication skills training program, and the fact that there is initial improvement does demonstrate that they can learn these skills. But if they go back to a setting where they're being pressured to see more and more patients, and where these sorts of skills are not valued, and where there's no rewards given for effective communication, then the behaviour will extinguish, as you say. So there needs to be system-wide encouragement and endorsement of the importance of these skills. Otherwise, individual clinicians, there are some fantastic examples of people who do manage to make this a priority, but it's more likely that the majority won't without that system support.
On a very basic level, thinking about the patient now, communication is an issue. It's rarely perfect. Is there anything patients can do when they come to see their doctor that would make it less likely that a problem would occur? Is there anything you can advise?
I do think that it's a two-way process, and communication occurs between more than one person, or it's not really a communication. So we've always felt that interventions have to be there for both the health professional and the patient, and they don't work unless both parties come in together willingly. So yes, patients can think about the questions that they have before they come in. Sometimes you need to practice asking the question, because it can really be difficult to do. And we're used to seeing doctors as being, somewhat godly, and particularly for some cultures, it's difficult for patients to assert themselves and ask their questions. In fact, health professionals welcome questions because they want to meet patients' information needs. So thinking about the questions, practicing them, bringing someone with you to support you and to remember things when you've forgotten, all of those things can really help.
Do you think it's important to bring a friend, family member or ally, but particularly if there's nobody available, should the hospital or the organisation be supplying an advocate? I know it's very patchy whether patients are supplied by somebody if they'd otherwise attend alone. What do you think about that?
Well, certainly there have been programs evaluated where there's almost a patient coach or a patient partner who works with people before they come into the consultation to identify the questions that they have and are then present to support the patient. It definitely helps.
Yes.
Not all services are committed to providing that sort of approach. And some patients prefer not to have it, which is up to them.
Okay. Considering the huge range of research you've been involved with directly and via collaborations around the world, nobody would claim everything's been found that needs to be found. There's still gaps. What do you think are the research priorities for the next few years?
Within my area of communication, I can speak with probably most authority. I think there are actually lots of gaps. I think there are populations that we haven't worked with. A lot of communication research has been done on English-speaking breast cancer patients, and you know, whether men have the same communication needs as women, people with different sorts of cancers, and particularly people from different cultures, where there may need to be adjustments to what we recommend. That's a real gap. We often focus on just the doctor and patient and ignore the family members and other people who come to consultations. We know that a lot of decision making and a lot of you know, discussion about treatment options happens outside the consultation room with the family, and that family members often have more needs and concerns than the patient themselves. And so working around how to communicate when there's more than two people present is a real gap. That's just two examples, but I think there are lots of other areas that we need to keep working with.
Well, I think those are very important areas too, and I want to thank you for sharing your expertise with myself and the viewer today. I've certainly taken a lot from what you said, so thanks a lot for joining with me and having this brief chat about the importance of psychosocial issues, particularly communication, on the impact on patient care. Thank you very much.
Thank you, Alex. I've enjoyed talking with you.